Thank you all for being patient. We'll go ahead and get started with our lectureship. Good afternoon. My name is Dr. Tyler Smith, and I'm the Associate Dean of Diversity, Equity, and Inclusion here at UMKC School of Medicine. Welcome to the 2021 Dr. Reaner and Dr. Henry Shannon Endowed Lectureship in Minority Health. This lecture is part of the University of Missouri Kansas City School of Medicine's Dean's Lectureship, named and sponsored in honor of the first Associate Dean of Minority Affairs, Dr. Reaner Shannon, and her husband, Mr. Henry Shannon. The lectureship was created to promote continued learning and education, as well as bring awareness about medical issues and health disparities impacting people and communities of color. The lectureship typically occurs on the last Friday in February for students, residents, fellows, faculty, staff, and the greater Kansas City community. Dr. Joycelyn Elders, the first African-American Surgeon General of the United States, was the inaugural speaker in 2006. Since that time, the lectureship continues the tradition of hosting dynamic speakers who are local, regional, and national leaders in medicine, including UMKC School of Medicine graduates and faculty members, such as Dr. Karen Bacom, Dr. Dana Thompson, Dr. Tim Hickman, and Dr. Michael Moncure, as well as leaders in government health agencies and professional medical organizations, such as Dr. Lewis Sullivan, Dr. J. Nadine Gracia, and Dr. Alpha Stewart. A few housekeeping tips. Please keep your sound muted so we are able to hear our guest speaker, Dr. Harris. Please place any questions into the chat and we will answer as many questions as time allows. It is my honor and privilege to introduce the 2021 Shannon Endowed Lectureship speaker, Dr. Patrice Harris. Dr. Patrice Harris, a renowned child and adolescent psychiatrist from Atlanta, served as the 174th president of the American Medical Association and the first African-American woman to hold this position. As a private practicing physician, public health administrator, and patient advocate, Dr. Harris has been an active leader in organized medicine for her entire career. She has served on the AMA's Board of Trustees since 2011, including a term as chair. She has also served as chair of the AMA Opioid Task Force since its inception in 2014. Beyond the AMA, Dr. Harris has held positions of leadership with the American Psychiatric Association, the Georgia Psychiatric Physicians Association, the Medical Association of Georgia, and the Big Cities Health Coalition. A distinguished fellow of the American Psychiatric Association, Dr. Harris continues in private practice and currently consults with both public and private organizations on service delivery and emerging trends in healthcare. She's an adjunct assistant professor, in the Emory Department of Psychiatry and Behavioral Sciences, and an adjunct clinical assistant professor in Psychiatry and Behavioral Sciences at Morehouse School of Medicine. Dr. Harris is a West Virginia native, and she earned her MA in Counseling Psychology and MD at the West Virginia University. It was during this time that her passion for helping children emerged, and she completed her psychiatry residency and fellowships in child and adolescent psychiatry and forensic psychiatry at the Emory University School of Medicine. It is with great pleasure that the Shannon Endowed Lectureship and the University of Missouri Kansas City School of Medicine welcome American Medical Association immediate past president, Dr. Patrice Harris.
Thank you, Dr. Smith. And I can't tell you what an honor and privilege it is for Dr. Shannon to be in the audience. As you heard, I was born and raised in West Virginia in a small town at the southern part of West Virginia. Didn't have family members who were physicians or family friends who were physicians, but there was a TV doctor, Dr. Marcus Welby, and I know the younger folks in the room are going to have to Google Dr. Welby, and maybe some of you about my age will recall Dr. Welby, and he was a kind, white-haired doctor who not only took care of his patients inside the exam room, he took care of his patients' needs outside of the exam room. And that certainly appealed to me. I actually did not meet my first African-American woman physician in the flesh until after I completed my undergraduate years. And so, Dr. Shannon, thank you, because I know that as an African-American woman, there are shoulders that I stand on Some people I know and some people I don't know and will never know, and have the honor of meeting you here today, because I'm sure you know that locally, regionally, spiritually, you paved the way for many others to come after you. So thank you, and what an honor. And I'm so glad that we can at least connect via Zoom. Sorry, I could not be there with you, but hopefully there will be opportunities in the future for us to get together. And I was talking a few minutes before the lecture began that I was rooting for the Kansas City Chiefs, but not as a fair weather fan. I am old enough, although I was a little girl, to have followed the Chiefs in the late 60s and the early 70s. And my father was a huge football fan. I'm an only child and watched football with him. And so I've been a fan of the Chiefs most of my life. So congrats last year. And of course, there will be more for your talented team. And as long as they are not playing my beloved Atlanta Falcons, I will pull for the Kansas City Chiefs. So I'm going to share my screen here today and talk to you a little bit about leadership. I'll be sharing moments of my leadership journey, my thoughts about leadership. I will be sharing leadership opportunities of the American Medical Association over this past year, and really talking about the importance of all of us taking up the mantle of leadership pre-COVID, during COVID, post-COVID, because I think we can all agree that we have a lot on our to-do lists going forward post-COVID, and it's going to require leadership. So I want to do a quick check to make sure that you all see my screen as I bring up the slideshow. If Dr. Smith, yes, she is nodding. So I want to say a little bit about leadership, though, because all of us in this room are lifelong learners because of the professions that we chose. And I can tell you there have been so many learning moments during the course of my career. One is the importance of advocacy. I learned that at the end of my fellowship training when I went down to the Georgia General Assembly. And I saw that the legislature was making a lot of decisions that impacted our ability to take care of our patients. And so it is critical to be engaged in advocacy. Another lifelong lesson is the importance of working together. The advocacy wins at the Capitol, in Georgia, in DC, in your state legislatures typically don't come because someone is working in silos and without partners. And so it's very important for all of us. And I know we have a multidisciplinary audience today. And listen, we won't always agree on every piece of legislation, but I can imagine that we agree on more than we disagree on. And so it's so important to work with partners as we lead, again, through this health crisis and beyond. Another learning moment in my life was around social determinants of health. I was able to speak with a smaller group earlier today, and I recalled during my residency, and we had a residency training clinic in the child and adolescent psychiatry department, we had a no-show rate of 75%. And we lamented and we lamented, why aren't our patients coming in? And I had an aha moment and realized that there are so many barriers to the patients that we were serving: transportation barriers, financial barriers, the ability to have childcare if you have more than one child and one child is coming in for services. So clearly that was an early lesson learned, but I think we can all agree that the importance of addressing social determinants of health has come to the fore, particularly during this pandemic. Another learning opportunity for me is the importance of speaking truth to power. First of all, truth telling. And I think as we again navigate our way through this pandemic and we talk about public health and a poorly funded public health infrastructure and a poorly funded mental health infrastructure. And we have certainly not had enough conversations around health equity. Yes, we have had conversations around health equity, but I think we can all agree these conversations are brought to the fore. And one of the many reasons is because we cannot look away during this past year with all of the things that have happened. And I'll be sharing more about those in my lecture. But it is always important that we commit to truth telling. And I always have practiced speaking truth to power appropriately, respectfully, strategically, but certainly an important lifelong lesson for me. Another learning moment regarding leadership is embracing the disconfirming opinion. It is certainly always easy when we agree on everything, and it is sometimes difficult if you are in the room and you are the only one that has a disconfirming opinion. But I believe leadership requires us to make sure we voice appropriately, respectfully, strategically disconfirming opinions. And finally, leadership is not about the title, although it can be about the title, and having the platform of the presidency of the American Medical Association has been a privilege. But it's not about the corner office, not about the parking spot. I always tell folks that leadership is about the work. You have to be committed to the work, because there will be moments, again, where you are leading out loud, as I have had the opportunity to do. But there are so many more moments in my life when I've been the quiet leader. So many times I've had the opportunity to lead an organization in a different direction, lead a person in a different direction. And no one will ever read about it on the front pages of a newspaper or even a professional organization's magazine. But it's important that we lead and we be committed to the work, because for so many of those leading opportunities, you might not get the credit. But I think it's so important to be consistent and true to the work. I do want to say thank you, though, and take this moment to thank all the healthcare heroes out there. We don't do this enough. This has been a very difficult time. It continues to be a difficult time. I receive so many emails, particularly from mental health professionals who are having a difficult time. You know, most often we put ourselves last. But we have to remember that, at least remember hearing this when we used to fly, you know, put your own mask on before helping others. So I just want to, on behalf of myself and on behalf of the American Medical Association, thank you for all of the work you have done getting us through this difficult time, and all of the work that you will continue to do, and encourage you. And by the way, I have to keep reminding myself of this every day, to take a moment, feel how you are feeling, honor your own feelings. As I said, we each need to give ourselves the grace and the space to feel how we are feeling, and make sure we are practicing self-care, not only during this difficult time, but always. And so lots of opportunity for leadership, again, at the federal level, and we have a new administration, although, and I can let you know, and I'm sure you know this as well, that it doesn't matter the administration, at least from the AMA's perspective. What matters is our quests to get our policies enacted, again, both at the federal and the state level. And so we are encouraged with the new administration. We are encouraged with what we see thus far, with the commitment to implement a national strategy and provide the states with additional guidance regarding COVID. But I know we are all excited about the commitment of this administration to address health equity. Dr. Marcella Nunez-Smith, when I heard her for the first time with that platform, talk about social determinants of health, talk about structural racism, talk about the choices that folks make, talk about food deserts. I have to say that it was a moment, and I actually became a little bit emotional, because again, these issues are being brought to the fore. Now, not for the first time. We have been talking about these issues for a long time, but it certainly does add to the veracity of the work when these issues are raised and explicitly stated, of course, from the platform of the presidency. But so far, again, the Biden administration has made the commitment not only to the COVID-19 pandemic, but certainly to issues around health equity. And we want to continue to encourage the Biden administration to bring the issues of mental health to the fore. Because as I stated earlier, certainly this pandemic has uncovered a lot of the fault lines in this country. And we now have everyone paying attention to mental health, and we'll have to make sure that those of us in this room continue to lead, making sure that that is the top of everyone's mind. And so from the AMA, as we have led through this pandemic, we thought that there are some core tenets of leadership here. The first, if this is a public health crisis, we want to make sure that we were providing up-to-date evidence-based resources and information. We want it to be a source of trustworthy information. And so that, I think, is a hallmark of leadership. You want to make sure, particularly leadership in health, you want to make sure that you are leading and providing accurate information. There's so much disinformation out there, and I will speak about it in a second. Clearly, it was also our priority to make sure that physicians and practices and healthcare systems had the resources needed to navigate through the disruption. And it certainly has been a tremendous disruption, has been, still is. And we wanted to make sure that we were fighting for physicians and practices and healthcare institutions so that we can better serve our patients. At the end of the day, it is all about the patient. We've been working for years on eliminating obstacles to patient care, and that's been no more important than during this pandemic. Clearly, from our perspective, it is vital to have that connection with our patients. And I think we can all agree, I don't know about you, I was already providing services through telehealth, but there's no question that this pandemic has accelerated the use of telehealth. And certainly the federal government and state governments have been receptive in changing some of the onerous regulations and the lack of pay equity. I'm not sure in Missouri and Kansas, but certainly in Georgia, if you saw someone for a telehealth visit, you were paid less than for an in-person visit. Certainly there were all these issues around the type of equipment that you needed. And we need to know that not everyone has access to broadband. Not everyone has a data plan. Not everyone, particularly our seniors, seniors are not a monolith, but I've had lots of conversations with seniors during the course of this pandemic, and they just didn't have, they were not internet savvy. And so certainly the federal government and some states allowed services to occur via the phone. And so we will have to have evidence-based conversations about which of these regulations, we should continue to see relaxed and what we should not continue to do based on data. And of course, again, it's important as leaders that we always advocate for science-based policies that promote equitable opportunities for care. And I am sure you saw me a lot on TV. That was has been quite an interesting experience. But the message that we wanted to always get out there was we need to focus and follow the science and the evidence and the facts. Unfortunately, that did not always happen. We saw mask wearing being politicized. We saw whether or not you should shelter in place being politicized. And even though we did not have everyone on the side of science and evidence and facts, we thought it was important to continue to be out in front in public. This is an opportunity to lead, to talk about the importance of science and evidence and the facts. Another issue, of course, that has been brought to the fore is the unequal impact of COVID-19. And I had conversations with a couple of my colleagues that in some ways, this was a little bit unusual. Typically, we end up talking about the disproportionate impact after the fact, right? We didn't always have the data. But fortunately, some of our cities kept great data and that they saw
that communities, Black and brown communities, were disproportionately impacted by COVID, had lack of access to COVID tests. And unfortunately, now we are seeing disproportionate access to the vaccine. But again, to really assess this, we need the data. And that's why the AMA, during the early part of this pandemic, made sure that we called out the fact that this data was not always collected in a consistent manner. And certainly it wasn't always made available to the public. And so we urge HHS, CDC, all the relevant federal agencies to make sure they were collecting this data. And now here we are in this phase where we need to get vaccines in arms. And I know we've all had conversations around vaccine acceptance. I'm using that word deliberately. And again, like all of you, I'm always on my constant journey to make sure that my words honor the concepts and the needs and the issues and the challenges. Early on, I made the point that we should be careful not to lump everyone who had questions around vaccines into the same category. We all know about the anti-vaxxers who are putting out misinformation. But in Black communities, there is reason to mistrust or take immediately at face value information around vaccines. We know the stories of Henrietta Lacks. We know the stories of the US Public Health Service experiments at Tuskegee. And another side point I will make here, you note I did not say the Tuskegee experiment because it was the United States Public Health Service that was in charge of those studies. And so we need to make sure we are not labeling Tuskegee with being the reason. The experiments were conducted at Tuskegee by the United States Public Health Service. We all know about the surgery, gynecologic surgery on enslaved women, and even in the 60s without consent. So there is reason for Black and brown communities to ask additional questions. And here we want to make sure that we get them the information that we need. We respect their questions. We ask them what they need from the medical community, the health community, in order for us to be trustworthy. Hopefully we are talking more and more about, and again, this is just not for the vaccines, we're talking about the need for diverse trial groups, but also the need for diverse clinical investigators. And this is all a part of what we should be doing as we move forward to decrease issues around health inequities. But back to the vaccines for a moment, fighting the misinformation has been a priority for us, and even at our AMA House of Delegates. And I'll just do a quick aside. I know sometimes the AMA can seem a bit of an opaque organization, but I can tell you that our policies that you learn about from the AMA are not developed by a small group of folks in a room. I am one of 21 board members, but we have a very robust democratic process in developing the policies, and many of our policies, and they run the gamut from health inequity to public health to payer issues, and so tobacco and HIV and reproductive health. And so our policies run the gamut, but clearly we had a focus just this past year on policies related to vaccine misinformation. And I hope all of you, the title of this slide has physician's role, but I hope all of you realize that, again, being a leader in your own sphere of influence, you have a perfect opportunity to answer questions, or if you're uncomfortable asking questions, making sure your patients get their information from reputable sources. And as we all know, not every source on social media is reputable and is providing accurate information. And so we all have a role to play in actually not only vaccine acceptance, but other acceptance of other treatment alternatives. Speaking about mental health, again, we continue to have a role in making sure that folks are getting the information that they need. There's so much stigma. And as we talk about inequities, particularly in Black and Brown communities. Now, the next couple of slides I like because I particularly make sure that I show these slides. This audience is a healthcare audience, and so you appreciate this already. But I get the opportunity to speak before a lot of non-healthcare stakeholder audiences. And I think sometimes when people think of healthcare, they think of nurses and doctors and psychologists and therapists and hospitals. And that's it, right? That's the universe of healthcare. And really, we need, again, another opportunity for leadership is to broaden the conversation, broaden the narrative about what contributes to health, what creates health, what detracts from health. And we have to make sure that those who don't know appreciate the broad landscape of factors that contribute to health. And here you see, we talk about the social inequities, institutional equities, opportunity. We have to have the very sometimes difficult conversations about racism. You know, racism is difficult to talk about, right? Our own implicit biases, difficult to talk about, no question. But you heard me talk about truth telling early on. We have to have these uncomfortable conversations. And it is up to institutions, universities, the AMA, businesses, Fortune 100 companies, Fortune 500 companies, to make sure they are having these conversations and to make sure that the folks around decision-making tables about
Good morning,
how
Mark.
to have these conversations are a diverse
Hey, trying to
group
get in contact with
that
you. I talked with
the stakeholders.
Gavin
And I know
Hall,
someone, I think I'll
from
just,
the
I think someone needs to mute.
I'm sorry.
I've done that before, so no worries. And so again, we have to talk about living conditions as we talk about the social determinants of health. Earlier, we were talking about the educational system, and we all can see the inequities in our school systems through this COVID-19 pandemic. Well, why is that? Because sometimes we have to go upstream, right? We have to look at the reasons. You know, what happened in the 50s and the 60s with redlining? For those of you who don't know, those sort of discriminatory lending practices, where if you were Black and Brown, you were perhaps only approved for a loan in a certain part of town. And perhaps that part of town or that neighborhood was close to an environmental hazard. And of course, if you live next door to an environmental hazard, your property values are decreased, which means decreased taxes. And taxes is how we fund our educational systems. So we really have to have conversations about those upstream determinants: affordable housing, pro-equity policies, systemic issues, quality education, good paying jobs. And then we can talk about the downstream. Of course, we need to talk about the downstream, and we can talk about behaviors, but we have to appreciate all of these in their larger context. Now, I belong to a group here in Atlanta called the Atlanta Regional Collaborative for Health Improvement, and we talk a lot about the need to invert the burden away from the individual and onto us in the healthcare system. I don't know about you, but even when I have to navigate the system when I am a patient, it's difficult. I always tell this story. My mother passed away from colon cancer in 2007. And around that time, my physician said, since you have a first-degree relative who has died from colon cancer, you need to start your colonoscopies earlier than is recommended. So I scheduled my colonoscopy, and I was denied payment from my insurance company. Now, I knew exactly what to do. It took me one phone call. I'm a physician. My mother this is what I said to the person who was deciding whether or not the insurer was going to pay for my colonoscopy. First of all, I'm a physician. My mother just died, and literally she had just passed away about 2 months before from colon cancer. And I went through all of the data, and it was an easy yes. I mean, all of us have probably been on the phone trying to get a prior authorization, and we know what a struggle that is. But what if I didn't have all that information or know that, and didn't have, it wasn't a physician? a person of privilege. So we really have to be about inverting the burden. And I think this goes not just for healthcare, but really for anything. Earlier, someone asked about our teachers and our teachers' mental health. And we have to make sure that the burden is easy and we routinize seeking help. We normalize seeking help. So we really have to do all that we can to invert the burden away from individuals. We have to meet people where they are. And this slide, I'm sure you've seen this cartoon in the middle. And how many times have we heard, although we don't hear it as often as we used to, well, I think we'll just give everybody the same thing, right? Or I treat everybody the same. And in actuality, we should not be doing that. And sometimes people get a little uncomfortable here because we like equity, or we say we do in our society. But look, each person has their own unique individual needs. And so we should be about giving folks what they need to be able to see over the fence. The littlest guy here needs 2 boxes. And that's okay. That should be okay. And so we should think about, again, inverting the burden, making sure folks get what they need. And what about this issue of individual choices? You folks have high blood pressure because they eat poorly. Well, what if you live in a food desert? And what if you don't have a lot of choices? So when people talk to me about choices, I say, yes, choices. But we have to realize that the choices we all make are based on the choices we have. And we all don't have equitable opportunities for the same choices. I have a car in Atlanta. I'm a physician. I have a good job. I have health insurance. I can drive to the grocery store. It's not far away. I did a panel with some of my colleagues in Tulsa, and he talked about if you live in the zip code in Tulsa that has one of the lowest life expectancies, it takes 2 hours on a bus to get to a location where you can purchase healthy, nutritious foods. And so we have to really have those conversations. We have to also talk about things that most people might not immediately discuss as part of public health. Police brutality is one. It is certainly one that the AMA took on this summer. I authored a column with Jesse Ehrenfeld, who was the chair of the board at the time. I was president at the time. And we labeled and talked about police brutality as a matter of public health. If you think about that, and again, probably those of us in this audience know that in the health care arena. But the AMA has had, by the way, and this was not new policy for the AMA, but we had long recognized that physical or verbal violence between law enforcement and the public is a critical determinant of health. And so these are the sometimes difficult conversations that we all have to have. And I always just to share, because sometimes we need to be honest and talk about the times when we are not okay. And I cannot tell you that so many of my women physician colleagues had a tough time here. I don't have children, but they had children, particularly sons, and this was very traumatic for them to talk about because they knew that their sons' lives are at risk on a daily basis. When I gave my farewell address at the AMA this summer, I showed a picture of the men in my family who just the summer before were at my inauguration, all dressed in tuxedos at the Hyatt Regency Chicago. But I noted that outside of the walls of the Hyatt Regency Chicago, they were not always safe to walk or drive or jog. And so we really have to make sure we are having these conversations and having conversations around racism. And so this summer, the AMA board pledged action, and subsequently in November, the House of Delegates passed policy regarding racism being an urgent threat to the public. And so again, sometimes difficult conversations, but institutions such as the AMA and your institution, we have to have these conversations. And it starts with leadership at the top. And Dr. Smith, let me just give you let me help you out here. And Dr. Smith did not pay me to say this, and I say this in all seriousness. For so long, we've had the responsibility of fixing equity problems, diversity, equity, and inclusion problems with the person who is the diversity, equity, and inclusion officer. We really have to invert that burden, right? The leadership, all of us have to take ownership and accountability. It can't be Dr. Smith's responsibility to fix it. Dr. Smith can be the coach, she can be the quarterback, but institutions have to take this on, and the AMA has taken this on. First of all, many of you may know that years ago, if you were an African-American physician, you could not join the AMA. In 2009, we officially went on record and apologized. That's part of that truth telling. By the way, that wasn't the end of the work. And we are still on our journey, and all institutions need to still be on the journey. In 2019, we launched our Center for Health Equity, and we hired our first Chief Health Equity Officer, Dr. Aletha Maybank. And here you see some of the goals. And we actually don't want Dr. Maybank to fix all the problems. Our goal, we are on our journey to embed health equity into the DNA of our organization across our
shared in the chat, bud.
Across other units that are not.
Open up the document within the chat. I'll share it one more time.
Our Center for our General Counsel.
Editable access.
Very committed to making sure, and we want to be the model. We want to lead the way. Not a perfect organization.
So just like we've done before with jam boards.
But it is about the journey and not the destination. We also are committed, and I'll just say a little bit about my journey into leadership at the AMA. I didn't just wake up one day and say, I want to be president of the American Medical Association. I think I'll run next year. I think all of you know that in organizations, the AMA is a very political organization, as it should be. But 25 years ago, the American Psychiatric Association, because I started as a delegate in that House of Delegates, a Congress of Medicine from the APA, but we were strategic, intentional, and deliberate. And we said we wanted to make sure that psychiatrists were a part of all of the relevant committees of the AMA, and that one day we wanted a psychiatrist to be the president of the AMA. And that was a 25-year journey, deliberate, intentional, strategic. And I think you can say the same is required to address issues around integration of mental health. The same is required to address issues around health equity, public health, all of these needs. You have to be intentional about this work. It's not just going to happen, right? You have to put resources behind this work. You have to put metrics behind the work of integration of mental health, of health equity. You have to hold people accountable, and it starts from the top. And so, you know, we wanted to, in our journey, to get psychiatrists in all leadership positions to make sure that the voice of our patients, the needs of our patients' mental health was integrated into the overall work of the House of Delegates. And if you're ever bored and you want to go to the AMA's website and look at our policy on mental health, just go to our policy finder, use the search terms mental health, and you will see that we have rich policy at the AMA regarding mental health. We have rich policy at the AMA regarding protecting patient access to care. As you all know, we were supportive of the Affordable Care Act, and we believe that that is the best path forward to build upon the success of the Affordable Care Act. As you know, there was recent legislation and rollbacks from the prior administration, and so we'll have to go back and build back on those. I believe, of course, the current administration, it was there at the time of the Affordable Care Act plans to do so. The AMA certainly was we wrote an amicus brief regarding Texas v. Azar. Amicus, this is a part of the AMA, just doing a quick piece of the AMA. You know, we battle in the legislatures, but we also battle in the courts. And we are very engaged when there were those very burdensome and onerous laws around reproductive health and the interference in a woman's, and it's not advocating any particular choice, but making sure that there's no interference between a woman and her physician to make the choices that she thinks, choices that are safe, evidence-based, and legal. And so certainly that we have continued to advocate for access to care and affordable, meaningful health insurance. And clearly, and I stated this, that we're very glad that the Biden administration is opening up enrollment for those who have lost jobs. Chronic disease, we cannot forget about. It costs us a lot, both in human toll and in cost. And so really, we have to be about the business of prevention. Some people are surprised when they hear the AMA is about the business of prevention. We chose diabetes. We thought and we asked, what if we could intervene at the level of pre-diabetes? And so we have a robust program and partnerships. Remember, I talked about partnerships to prevent diabetes, working with the CDC, working with the American Diabetes Association. And so that is work that is continued. We've been focusing a lot on heart health for Black women. Black women often are surprised when I talk to them about their heart health, worry appropriately about breast cancer, worry appropriately or concerned or making sure about cervical cancer, but don't always have heart health top of mind. And so the AMA, along with other partners, are very proud to partner on this Release the Pressure campaign. I encourage you all to go to the Release the Pressure website. There are resources for you to talk with your patients, and in general, these go for everyone, but particularly we wanted to make sure we were focused on Black women and their heart health. Increasing diversity of the physician workforce is key. You all know the statistics, and we certainly have a ways to go, particularly around Black men. And the AMA, again, has developed policy to support all of you in that. We've had some long standing initiatives, clearly, not enough. And this is where partnerships are important. Our AMA Foundation has long been critical in minority scholarships for minority and underrepresented students. We have this Doctors Back to School program. If you can see it, you can think about being it. Certainly working through the courts, fighting to uphold DACA and support for our international medical graduates. We are very proud of our Accelerating Change in Medical Education initiative. About 8 years ago, we awarded $1 million grants to 11 medical schools to support them in innovation. Listen, medical schools are already innovating. You're already innovating, but we wanted to elevate that with the platform that we have at the AMA and support learning. And since then, we've developed a learning consortium where medical schools can learn from one another. And folks are working on social determinants. Folks are working on technology. Folks are working on increasing diversity. And so we're very proud of the work and the textbook and folks leading the way, because we really have a long ways to go. And by the way, I want to say something about the Flexner report here. We've had conversations at the AMA. And this is digging deep, and this is what institutions must do, must dig deep. Many of you, if you're not, I won't give you a history of the Flexner report, but the AMA was a sponsor of the Flexner report. And look, the overall goal was to standardize medical education. Who could argue with that? But in the midst of that work, several Black medical schools were shut down, because of course medical schools were segregated at the time. And so you wonder, you have to ask, you have to have the conversation. Did that lead to where we are today with certainly not enough people from communities of color in the medical profession? So we are digging deep on that and looking at what we've done. And that's what every institution needs to do going forward. And so I'm sure many of you, as I was, were wowed with Amanda Gorman at the inauguration of the Biden-Harris administration. And I loved everything she said, but one of the most important things she said was the end of this quote here. And even as we think about COVID, and as we think about health inequity, and as we think about racism, and as we think about police brutality, it can be overwhelming, right? It's a lot on our to-do list. And we do ask ourselves sometimes, I know you ask yourself, I do ask myself, how can we possibly get through this and prevail over this catastrophe, these catastrophes? But Amanda gave us hope, and she said, how could catastrophe possibly prevail over us? And so I, again, thank you for the opportunity to be with you today. And I look forward to questions and discussion.
Thank you so much, Dr. Harris, for that amazing presentation. Thank you so much for providing more insight in how organized medicine and other leaders in healthcare can help us create ways or build up strategies to offer more equity, not only in healthcare, but also in society as a whole. So thank you so much. And so just to briefly, I want to say, my name is Doris Ogwood, and I'm the Assistant Dean of Diversity, Equity, Inclusion for the School of Medicine here at UMKC. So if any of you have any questions for Dr. Harris, please put them into the chat, and then we can kind of have this question and answer session with Dr. Harris while we have her here at the time. So I will guard the chat, and I'll just continue asking questions as time allows and as questions come in. And so the first question I would like to ask you, Dr. Harris, is as we're here speaking to people who are training in the medical field, either medical students or fellows or residents and things of that nature, what would you say are keys to developing the next generation of leaders within healthcare?
You know, there's so many, but I would say that we need to make sure that we ask them what they need and nurture them through this process. And I think a key is making sure that our next generation of leaders are around decision-making tables as we're planning. Whatever you're planning, make sure that they are around decision-making tables. Now, I have to say, you know, whenever I go around the country and in person and when I attend our AMA meetings and see our medical students, I often say, I feel like a slug. And in my opinion, there's no way I'd get into medical school these days because these young students and medical students are so talented and they have so much to teach us. They are on fire for these issues that I think broaden the narrative about what we should be thinking about as we take care of our patients. And so I believe we should sometimes just listen because they have so much to offer. Now, I will say this, and I've had the wonderful opportunity to give a couple of commencement addresses over the last couple of years. And I think we should all honor one tenet, is no one generation has the market cornered on the right way to do things or knowledge. And so we should definitely respect intergenerational learning. There's so much, as I just said, that we can learn from our young learners. And I say to the young learners, although you might get impatient with us sometimes, there are things that we can teach, that us old folks can teach you as well. So we really need to make a commitment to coming together and listening. And I think in developing, I am on fire for advocacy, and I think we should develop advocate and support advocacy skills. I think we should develop some business skills for our young learners. And I think we should develop what I call critical thinking skills, because there is no way, I can't imagine all of the information our medical students have to learn today. It's so much more than those of us who are attending had to learn. And I think there's no way to learn it all, right, in 4 years or 15 years, depending on what residency. What's important to me, though, is you leave medical school or undergraduate with a skill set to know how to critically think about information that is presented to you, because there's so much. And so I think that's what we should be doing in our young learners: critical thinking and also self-awareness. We have to sometimes look inward. I make it a habit whenever there's some intractable problem, I think about, okay, did I have a role in this problem? And it's a reflex question that I ask myself. And the answer could be no, but I think we should all improve on our skills around emotional intelligence and being self-aware.
Thank you so much for that answer. I'll move on to the next question just to make sure that we can get as many questions in as we can. So the next one is, what are some of the things that you believe non-minority physicians can do to improve the lives of our Black colleagues?
Yeah, this is critical to me, because we cannot invent doctors overnight, right? It takes a long time, for the process. And so at some point, maybe 50 years from now, we'll have greater numbers. But right now, and that's where and I really like diversity, equity, and inclusion. So our non-minority colleagues can sort of own the fact that, and be accountable for what each of us, but we're talking about non-minority colleagues, can do. Lead these conversations, support, and make sure the space is inclusive, right? Because if you recruit a couple of medical students or young faculty and the environment is not welcoming, they're going to leave, right? They're going to leave. And so, though I think our non-minority colleagues can make sure that they are asking hard questions themselves individually, but the institution, to make sure that the environment is welcoming.
Thank you. And the next question, and this is from Jacob Lee. They say, thank you so much for your time, Dr. Harris. As working in a safety net system, so much of what you say rings true. What do you think are the most important conversations to have with our patients in a clinic setting?
And we are trained sometimes, and I know I was trained, the history, chief complaint, and just sort of, and I think we should step back and ask a few more questions. For instance, patient comes in, they have not been taking their high blood pressure meds. What do we write? Non-adherent, and we move on to the next thing. And there are a couple of questions missing there. And I really like the concept of narrative medicine. What challenges do you have in taking your medications? And folks will then tell you their story, probably, right? But instead of just saying they're not taking their medications and on to the next, let's try to figure out why. Let's dig a little bit deeper. So I think it's about having a shift in mindset, and it's not just sort of just getting the symptoms and moving on to the next, but spending a little more time in the fuller narrative of a patient's life. Now, again, because I know folks say, well, we can't fix all that, Patrice. I can't fix housing. I can't build housing. And that is true. But we have the privilege as physicians, medical students, of getting the data and the information about the needs. And then we can share that information to those who are tasked with and should be partnering with us on housing and on all of the other issues. So we get so much information in our interactions with our patients. And so we can use that information in broader systems.
Absolutely. And so the next question, how can diversity, equity, and inclusion initiatives move from being political correctness to empowerment of targeted vulnerable populations and communities?
Well, first of all, it's got to be leadership from the top. So I'll just say, and I say this too, this won't be the first time I've heard this, the president of the university has to say, this is my issue, and I'm accountable. And I'm developing metrics in all the chairs of the, so the dean has to, take this on, or the provost has to take this on. And there are metrics, and we're going to have metrics. Everyone, all the chairs have to have metrics. And again, not just numbers, right? It's what policies, have you done a policy review? What pictures do you have in your, when folks come to your facilities for care, what photos do you have up? Do people see themselves in the physical plan? And I realize the physical plan is not a service, it's not treatment. But those are the things that matter. And the other issue is we have to go to the communities that we are serving, and ask them what they need. Because we could decide, we could sit around the table and say, well, this is what I think this community needs. We've got to engage the community. But it starts with leadership at the top, accountability, resources, and metrics.
And what I really enjoy about your answers to each of the questions is that it actually incorporates some of those key items you talked about in regards to how we can form leaders of the next generation, of being self-aware, having that introspection, not just of yourself, but your organization, your institution, and then also listening. So asking people what are their needs and taking those into account. So thank you so much for that. Our next.
Gross is so hard to clean.
I think someone needs to go on mute. Thank you. Our next question. What are some of the challenges you face as a woman of color in being actively involved in leadership in a professional organization?
Well, it's not always easy. It hasn't been always easy. Oftentimes I've perhaps been the only woman in the room, the only woman of color in the room. Now let me just say this, but I am by no means comparing myself to President Obama and Mrs. Obama. But sometimes when you are the first, you know that you can't make a mistake. And, and I, of course, you accept that. Otherwise, why did I do this thing and run and want to be the first woman to be the president of the AMA? But you do know that people are watching. And that's that's good. It has it, but it's also it's a privilege, but it's also a responsibility. And then the typical things that a lot of women, I'm sure every woman on this call has been interrupted, been talked over, been discounted. And so, all of those things I've struggled with or encountered in my journey to leadership. And I'm now talking even broader than the AMA, just in many rooms that I've been in. But you persevere because you know that the work again is greater than the issue or the moment at that time. And this is where you need, I said women, or, Valerie Montgomery Rice, who's the dean of the Morehouse School of Medicine, she said, everyone needs a posse. And so this is where you make sure you have your circle of support. And by the way, they can be folks, I have my friends, my sorority. I have to just, we know the vice president is a member of my sorority. Just put that little plug in there. But I have friends since college. And, who have always been supportive of me. They're not in medicine. One's a physician in West Virginia, but, so you have your posse, you have your circle of support. So when you're in those situations and you're exhausted and you're drained at the end of the day, you can go to those folks and get, re-energized. And as I say, live to fight, another day. But yeah, I've had, all of those experiences. And then you have the experience where you're sitting in the room, you're the only African-American, and there's a conversation and, and I'm being a little bit reductive here, but, well, we need to figure out what Black people think. And then, they turn to you. And this is something that I'm sure many of the communities of color think. And so at that moment you say, okay, Black people are not a monolith. I cannot speak for all Black people. I cannot speak for all Black women. I cannot speak for all women. It depends on the audience. But then at that moment, you also realize that you have a lived experience that, of course, if you're the only, no one else has. And so at that moment, you have to say something, or at least that's, what I've chosen. And there are different choices in different settings, and you have to be strategic and all of those things. But, those are just some of the challenges that I've experienced over my years.
Thank you. And so I do want to be respectful of everyone's time. So we'll just do one more question. And this comes from Jessica Hellings. And they write, thank you so much, Dr. Harris, for all your work. Can you help us understand how we can help prevent homelessness, given that the predisposition to it often starts very early in life, and so many have mental illness.
Yeah, so homeless, I wish I had the answer for homelessness. And we all know there are different reasons for homelessness. We do know that there is a segment of the homeless population that has severe and persistent mental illness, but we also know there's a segment of the homeless population that's recently lost a job, that live paycheck to paycheck, that have no cushion. And so a month of two of a job loss means you don't have a place to stay. So I think we need to think about homelessness in that broader sphere. There's no question that if we're thinking about other than severe and persistent mental illness, we need to think about affordable housing. And so that comes from, I know it here in Atlanta, that's huge in Atlanta. And so you have to have policies, right? You have to have incentives for developers and builders, that we do in Atlanta, to create affordable housing. So there are creative strategies for housing, living wage, so forth and so on for that. For the severely and persistently mentally ill, we know that it's about treatment, right? We want to get folks in treatment as early as possible. We know the earlier you identify folks, the greater opportunity you have to not cure. We know our disorders, just like diabetes, it's not curable, but treatable. But does everyone have equitable access to the best medications, the medications, that have the least side effects, right? Because again, for many of our medications, and both psychiatric and non-psychiatric medications, they have side effects. And if they are severe enough that a person, says, nope, not taking that. And so, are there medications? Of course, the brand names or the newer medications typically are more expensive, perhaps not covered. And this is if you have insurance, but perhaps not covered if you have Medicaid. And then are we really giving folks an equitable opportunity? So, and then should we, the housing first policies I loved, and I've been through the gamut of the policy where in order to get housing, you almost had to be perfect, and I'm glad we're rethinking that. And it's housing first. I remember one of my patients, and I was the medical director for an ACT team, and he had schizophrenia, but of course he was able to, talk to me about his situation. And I talked about the housing, and he said, I know I can have a housing if I come into your program, but it's too many restrictions, Dr. Harris. I don't want to, I want to do what I want to do. And don't we all, that is the universal desire of all of us to live our lives. So I'm really glad we have, really embrace housing first, but now we need the funds and the resources to make sure we put housing first policy on paper into implementation.
Thank you so much. And so those are all the questions that we have time for. And within the chat, there are so many comments thanking you and just pretty much praising you for your wonderful insight on this topic and this very important conversation. So I just also wanted to echo that we're so pleased that you were able to take the time out of your schedule to chat with us for a bit. And we just thank you so much for your time.
Well, thank you. It was my pleasure.
Absolutely. Have a great day, everyone.
Have a great day, everyone.